we do have a bit of time. We have about half an hour before lunch. I would like to encourage people to speak up, ask questions, share experiences. Otherwise, it will be a very boring half an hour, or you can all go for a walk or something.
I must have talked too fast. Apologies for that.
No, it's fine.
How do you assess when to start treatment?
That's a really good question, and I think opinion on that does keep changing, actually. I, as a geriatrician, have always been very cognizant of the model of start low and go slow. And, you know, I often discuss with patients what their priorities are and what their goals are, and we try and come to a shared decision around whether it's the right time to start treatment. We do know that the longer people are on treatment, the more likely they are to develop adverse effect and tolerance. So you don't want to hit people really hard with massive doses of medication straight away. But equally, there is some evidence that shows that delaying treatment doesn't necessarily confer any benefit. So I think, you know, if you're comfortable with the diagnosis, if the symptoms are impacting on the person, if they feel, you know, it's time for them to want something to be done, that's probably when I would start a treatment. And I do take a sort of go low and slow attitude. Do you have a comment on that?
Our general rule of thumb is when your everyday life is being disrupted by your Parkinson's symptoms, that's when we would look at saying to people, well, perhaps if things are starting to become really troublesome, that's a good time to look at its commencing medication.
Yeah, I would agree with that. It's, you know, it's when it's impacting on the person, and again, you know, I alluded to this earlier. You know, how do you monitor treatment effect? And the reality is, in my experience, no one ever comes back and says, you know, I'm cured, because they're not, and they never feel 100%. And to some extent, you have to work with people to work out what level of ability or disability or symptoms they feel they can live with. And I guess the most objective way that we can assess treatment response is to look at function. So, you know, I routinely ask my follow-up patients, you know, how are things going? You know, who does the cooking? Who does the cleaning? Who does the laundry? Who does the shopping? Are you still driving? Can you still shower yourself? Can you still dress yourself? You know, you're not going to achieve 100% freedom from symptoms, but if people are functioning, then I would count that as a good treatment response. They may not be satisfied with that. They may want to feel perfect, but, you know, sadly it's not a magic wand, it's a medicine. So, yeah.
Thank you.
You're welcome. Please don't feel you have to address all your questions to me. Ask each other, ask our other speakers.
I was wanting to ask about physiotherapy and specific, like the physio, how you do steps and that sort of stuff, because I understand that can be really helpful. I guess I wanted to know, when is it worth doing it? Is it worth repeating? I have people that kind of need regular sessions with physio, which is private. You know, what's available around the place, really?
Yeah, I mean, it's difficult to answer the question what's available, because it obviously varies, you know, quite widely. I mean, I'm fortunate, as I said earlier, I work with a really great team, and I will be honest with you, I am not a physio. I can't tell you exactly what they do because I'm not there necessarily watching them while they do it. But, you know, I am lucky to be able to involve physio early if I think it's, you know, a reasonable thing to do. And then I trust the judgment of the physio to work out with the patient what's going to be the right approach and how long the treatment might be. There is definitely a role for repeated treatment if things change. you know, one thing I can tell you for absolute certainty, and I don't know how they do it, is that physios have the best PR in the flipping world, because everybody wants to see the physio and they want to see them forever. And I think, you know, we have to trust that those therapists know what they're doing and that they know when it's time to scale down or stop the treatment. But that doesn't mean it can't be revisited if things change. I wish I had $1 for every time a patient said to me, I feel I need more physio. I don't need to work.
If I could just say that in Parkinson's now we recognise that taking bigger steps and making bigger movements is something that's going to substantially aid the patient. So there is a program called Lee Silverman Big. It's all about making bigger movements, and some physios are specifically trained in this. It's called the Big program. It is not subsidised or offered through our DHB in the Hutt Valley. So our patients would need to buy this privately. It costs around $2,000. It's 16 sessions, so every day. It's for 4 days a week. It's tailored to the individual. So it's all about what they do, what is their lifestyle. Are they retired? Are they still at work? So we really recommend that if people can run to it. And most people can't, that's the reality. But when do we recommend physio? I always say as soon as the person starts to report difficulties with any motor function, get a complete physio assessment. So even on that first visit, I've got people who've said to me, I had one lady who said, I said, look, there are a number of things I could refer you for. There's physiotherapy, occupational therapy, speech language therapy, and she said, I want the lot, which is quite rare. But I just duly, even on that first visit, I duly wrote it all out, and she's done very, very well, extremely motivated, early 70s, still working, but probably a bit of a rarity in terms of patients. But we say as soon as possible, no wait.
And coming back to the previous question, you know, utilising these services if, as and when they're available and if people can afford them, can moderate the drugs you need to give them as well, which is, you know, I'm a big fan of not giving people lots of drugs.
I work for a multidisciplinary community team, and we've got physios in our team that do outpatients of the unit, so that anybody can refer to physiotherapy for Parkinson's stuff, even if it's falls prevention or any of that stuff. So I mean, as far as Wellington goes, we've got that service.
And they can be seen at home as well.
Yeah. I mean, you know, there is, I'm aware from my work with stroke that there's huge variability of what multidisciplinary services are available around the country, and you know, what's always good as well is you do want some allied health people to develop an interest in an area. So, you know, for example, I will be absolutely honest, I am not familiar with the technique that you just referred to, you know, so that's something that I would not have been aware of before or been able to refer to. But if you've got a physio with an interest in movement disorders who's prepared to do the research and learn these techniques and offer the service, then that's great. So
our guys were talking about a program that they were given that was similar to Big. It wasn't Big, but it was
a modified
based on
version.
those sort of ideas. So I mean, it just
In the diagnosing phase, sometimes people just present with the tremor.
yeah.
And could you remind me what can help me to differentiate between like an essential tremor and the Parkinson's?
Yeah, it's very rare that someone would only have the tremor. The thing is, they may, as you've heard, they may not volunteer other symptoms, so it's getting tuned into that asking. So, you know, I get a lot of referrals, thank you for seeing this patient with tremor, query Parkinson's disease, and many of them are not. You know, some of them will be essential tremor or other tremors that may be cerebellar tremor. You know, as with all aspects of medicine, the key to diagnosis is 95% in the history, and you've got to ask the right questions. So, you know, those other features people may not volunteer them, you need to ask. In terms of the actual physical characteristics of the tremor, it is typically a resting tremor. People, in particular in the early stages, often do have some control of it, so they can, if they concentrate or they do particular movements, they can stop it. It's often referred to as this pill rolling, and this comes from the olden days when pills were made by hand. And the way that you would do that is between the finger and the first two fingers and the thumb. And it isn't always, characteristically pill rolling, but it often is. And and it typically has a fixed frequency, so it's not a very variable tremor, it's the same sort of frequency. With regards to treatment, the tremor is the aspect of Parkinson's disease that's most unpredictable, I feel, in its response to treatment. And I tend to warn people of that, because if their tremor is their predominant concern, they may be very disappointed with the outcome of treatment because it doesn't always respond very well. Going back to what we were saying before, objectively, treatment is targeted towards function. It's about keeping people independent, active, doing the things they want to do. And at the end of the day, I have had conversations with people and say, look, the tremor is the aspect that, in my experience, responds least well to treatment. There's always some paradoxical person who has a brilliant response, but in general, doesn't respond well. And at the end of the day, you may have to accept that you're not going to order the soup in the restaurant and have something else. But as long as that person's functioning, again, would you care to comment?
Tremor is difficult.
Yeah.
It's difficult to treat, but as Jan says, a lot of people cope with it very well, especially they do things like, sitting on their hand or popping their hand in their pocket. So a lot of people will develop compensatory, behaviours.
So in contrast, essential tremor tends to be present both at rest and on movement. It's often a much finer tremor. So if you think of the classic tremor of thyrotoxicosis that we're all taught about but rarely see, it's more in keeping with a very fine, faster tremor. There's often a postural component to essential tremor, so it tends to be worse if people are standing. And it's familial, not always, but it can be familial, so it's definitely worth asking, have you had any other family members with a similar tremor? And one interesting phenomenon is essential tremor can improve with alcohol. It's not a recommended treatment, but people will often, if you ask them, comment that the tremor is less evident if they have a drink. Cerebellar tremor is typically intentional. If it's, it can be unilateral. There are some bilateral neurodegenerative cerebellar problems, but if someone's had a cerebellar stroke, for example, their symptoms are going to be unilateral usually. So it's an intention tremor. Those are the sort of differentiators really, but history. Always the
So would you
history.
say the history is way bigger than the physical examination?
Oh, absolutely. That's true for all medicine. Yeah, 95% of diagnoses are made on the history before you ever lay a finger on people, and tests contribute very little. And that's as true today as it was when I graduated all those years ago, as I'm sure Terry would agree.
Couldn't agree more, yes.
Yeah. The story is what gives us the clue. There's a reason why Sherlock Holmes was a doctor. Well, he wasn't. He wasn't, but he was written by a doctor, wasn't he? He was invented by a doctor.
Without sort of being morbid, could we talk a little bit about the dying of Parkinson's? What are the things people die with really, and being with Parkinson's? Related directly to.
Yeah, I don't think it's morbid. I think death is a part of life. As we were discussing earlier, sometimes I meet people who do have this perception that you can't die of Parkinson's. And the reality is, because it's a diagnosis generally of older people and people with modern treatments do live longer and live well longer with Parkinson's. There is a number of people with it who will undoubtedly die of something else. You know, you can have Parkinson's disease and still drop dead of a heart attack. But in the absence of other things that, you know, produce the end of life, you will die of your Parkinson's. And the likelihood is that there will be physical decline. So, you know, people do become frailer, less mobile. The complications of immobility then become apparent. But increasingly, the cognitive aspects of the condition are what we are seeing as being the major contributor to palliative care. So, you know, the risk of having dementia with Parkinson's is very high. Often it's of an Alzheimer's subtype. There is Lewy body. I'm not going to say any more because I don't want to encroach onto Terry's excellent talk. Dementia is the epidemic of our time. There is absolutely no doubt about that. We are living longer and longer from lots of things, you know, cancers, cerebrovascular disease, cardiovascular disease. The longer we live, the risk of dementing is very high. Those of you who came to the dementia seminar will remember that the last speech was about palliation in dementia. And if you weren't here and you haven't watched it, I would thoroughly recommend you watch the video of Sandy McLeod's excellent, you know, absolutely mind-blowing talk on why palliative care in dementia is the future of healthcare, really. Palliative care is an amazing thing. I have a husband who's a nurse practitioner in palliative care. But the model of palliative care that we're all familiar with is very much predicated on cancer care, and increasingly that is not how we die. And, you know, so it's always difficult. When do you palliate? How you palliate, again, is, you know, there has to be discussion. You work out what's important to the person, to their family. Symptom relief. When do you look at withdrawing medications? There's no easy answers to that. You've got to try and individualise it. Advanced care planning is, I think, really important for people with Parkinson's disease. You know, I always maintain that by the time a patient gets to see me, nothing is advanced in terms of their care planning, because by the time they get to see me, something's already happened and they've usually gone through primary care. But, you know, if you're diagnosed with a condition that you might live up to 2 decades with, but you know is going to get worse, it's a really good opportunity to put some advanced care planning in place and really think about what's important. So I certainly encourage that, you know, as early as possible.
I can tell an anecdotal story around it.
Please do.
I had looked after an 80-year-old lady in a rest home. She was in rest home level care with rapidly progressive Parkinson's disease, and she was still fairly intact cognitively, and I was able to have a discussion with both her and her very caring son, because it was becoming clinically evident that her Parkinson's was going to sort of unravel really, really quickly. And we sat down and we talked about what were the things we could see. She was on a lot of medication to control the symptoms well. And she made it very clear that she was embarrassed by her increasing immobility. She was increasingly embarrassed by the fact that she couldn't get to the bathroom in time to have a bowel motion, and also that she was now needing incontinence wear. And she was aware that she was afraid to be moved or to move because of the risk of falls. And so we talked about the fact that she was going to need hospital level care, and we sat down and we actually wrote down what the potential signs and symptoms would be for her that would precipitate her move to a different rest home at hospital level care. So we did this, and it was a very emotional discussion with a really caring son. But she was very clear, and she was almost clinical in her decisions, and it was really important to have that down. At that stage, also talked about what sort of symptoms she might develop and at what stage she was happy for me to start withdrawing the medication. It was really wonderful that they chose to go to a rest home where I could follow them up as well. It was a rest home where I worked as well. And there came a day when I went to see her and I said, and you know, we really struggled to move. I said, we need 3 people to move you today. And I said, you know, remember we wrote down on the day that I need more than 2 people to move me, we'll move. And so we did. So it was a very difficult movement from a place where she was very comfortable and she knew all the people. But this was her decision and we helped her to stick to that decision to move. It was really great. And then into a different rest home where we just kind of followed that advanced planning that we had done, we discussed it. And so my role really with the nursing staff working with us was to remind her, and eventually as her cognition rapidly deteriorated, reminding her son of the decisions we've made together and reminding, just kind of supporting that decision. And you know, she was literally in a new rest home for 8 months when she developed the pneumonia that we knew we were not going to treat. And it would have been very difficult if we not had that discussion beforehand. And very easy to stop the medication because it wasn't going to make any difference. And we stopped all her Parkinson's meds actually fairly rapidly over a 6-week period. And because we had decided beforehand when we were going to do that. So it was quite an emotional journey, but it was easier because we had actually discussed it beforehand. So
that's a
really good
great story.
How important it is.
All I can say is congratulations.
Well,
what a great story.
For her to be
Yeah, but I mean, you know, it's so nice to hear when it's done well and when it goes right. And again, you know, I was teasing earlier and I'm sorry, but you know, one of the commonest things I hear from GPs and practice nurses is we don't have time. But I guarantee you, if you put that time in at the start, you are saving time later because you're not having those conversations at a time when that person's critically ill and you're having to say, do I ring for an ambulance and send them into an ED that we know damn well isn't going to want them there and can't do anything anyway. And you know, that's healthcare done well. So I applaud you.
Can I ask a question regarding the use of magnesium for people that have restless legs, and it's also quite good as a laxative?
Do it. Try it.
Has anybody used it?
I am not personally aware of any specific research. Please remember that Dr. Bourke may know the answer to that question, or our colleagues here. I mean, but you know, try it.
So I get restless legs at night and only feet all day, and I find it really good. So I'm saying my dad's got Parkinson's, and I've tried it with him, but we haven't discussed it with his GP at this stage. But it is working for him. I just wondered if you use one any other.
I'm not averse to people trying anything as long as it's, you know, not complete snake oil that's harmful. I have patients who tell me they take magnesium and they say they feel better on it, and that's fine. I might check their magnesium level just to make sure it's not too high. And you know, I've got other patients who tell me if they put a bit of salt on their tongue, which is sodium, isn't it? And some people find that helpful. And again, you know, go for it.
Because magnesium is actually quite good at the use of a laxative as well.
I'll take your word for it. I've certainly not prescribed magnesium as a laxative, but I definitely have met a lot of people with restless legs who swear by it.